The next talk is entitled Informed Questions and Careful Observation Will Increase Your Sensitivity to Adverse Drug Effects and Help Protect Your Patients. And it is my great pleasure to introduce a close friend and colleague of mine, Dr. Tom Perry. Many of you know Tom Perry, but for those of you that don't, he is as handsome as he appears in the pictures in front of you in real life. He's a little quirkier than the pictures would indicate, but that's why we love him. Tom teaches clinical pharmacology and internal medicine to UBC medical students and continuing professional development for doctors, nurses, nurse practitioners, and anyone else who's interested. His outpatient practice focuses on pharmacological treatment for chronic pain and high blood pressure and reduction of pointless or dangerous polypharmacy. He encourages use of videography to teach and learn about drugs, which you'll see today, and to teach about pathophysiology. Since COVID-19, he has been adapting to online education using Zoom, which enlivened by the use of patient videos. And one thing I have to say about Tom is spending so much time with Tom over the last 15 years, it's fundamentally changed the way I think about everything. And I've become a more doubtful, critical thinker. And I think it's made me a better person. And much of that thanks is due to my exposure to Tom. And I'm sure you'll feel the same way. So with that, I'll pass it over to you, Tom.
Thank you, Aaron. Judy's going to put up a couple of slides, but while she does, I'm going to share with you how I think everyone can understand now why I was so intimidated to be instructed to follow Dr. Mandrola. But one saving feature is that he told us he's also a psychologist, so I can understand better now how he handles the uncertainty. And since Aaron pointed out that he's likely to be invited back, I'd like to notify you Dr. Charles Helm up in Tumbler Ridge in northeastern BC has a jump on that. Whether it will happen in June of 2021, who knows, but if we do get successful immunization against COVID-19, you might want to put in the back of your mind the idea of coming up to northeastern BC to dinosaur country and hearing John and hopefully his wonderful wife Stacy also sharing new insights and wisdom with us up there. And if it doesn't happen in 2021, there's always 2022. So I also want to, just while you're looking at this, you can see we've got a fairly diverse audience today. And the only thing I'm sad about is I would like to see more nurses there. I wouldn't mind seeing some more specialists too, but the audience includes a couple of people I'd like to salute in Great Britain and 4 in the United States and 1 in Brazil. So welcome to those of you who are participating from a long distance. And I want to take a chance to say hello to a lot of old friends. I noticed on the participant list, some friends who go back from to their medical school days in 1983, I think, and many senior colleagues around British Columbia and many distinguished teachers of medicine. So hello to all of you and thank you for joining us. And one last thing, if we can see the slide of how to sign up for about half of the people I think have participated in our courses before, but about half have not. If you would like to automatically be alerted to therapeutics initiative events at our website, ti.ubc.ca, it's very easy to sign up for alerts. It's at the bottom right of the home screen. And of course, we are not allowed to do that for you by privacy laws. So the fact that you signed up to this event with UBC Continuing Professional Development doesn't mean you get TI alerts. If you would like that, you need to sign up yourself. And you can always, of course, unsubscribe. So I think we're ready. I will see if I can find my presentation again and bring it up. And let's see what happens. I just having practiced this, of course, Lost it again, but let's see what
Do you
happens.
want to click on share screen, Dr. Perry?
Oh, yes, I'm sorry. Share screen.
And then select your PowerPoint presentation. And
Am I
place it
doing any
in.
better yet or not?
Nope. And then you have to put it in presentation mode.
Right, I just haven't, well, I guess I don't need to be able to see myself, do I? As long as you can see it, I'm happy. Are we there?
Yes, we can see you and your slides.
So the learning objectives are pretty simple for this. Thinking more about carefully observing patients for adverse effects of drugs. That would include, for example, someone who truly does have statin myopathy, and eliciting drug effects with skilled questioning. For example, since Dr. Mandrola discussed some issues of real adverse effects versus nocebo effects, asking whether someone is still active in physical activity. I think of various presentations I've given where people came up to me afterwards and said, you know, my mother used to go cross-country skiing from Vernon or Kelowna in the interior of British Columbia and now can't do it anymore. That should be a clue that somebody might have a statin myopathy. And the more and more skilled one gets at listening carefully, the better one is going to be as a practitioner. And then knowing when to measure, record, and interpret changes in vital signs caused by drugs, using low standing blood pressure as an example. This is a very important issue, and I'm seeing in the last few years that almost nobody in my field of medicine seems to be actually practicing as they were taught. I'm going to show you a number of videos, 7. I'd just like to remind everyone the patients consented to my recording the video for healthcare education. That includes everyone who's participating today, but do not record the videos. I don't have consent for other people to share them. And if you recognize anyone, which you might, respect the privacy of that person as if they were one of your patients. And there will be, right after the videos, after 5 of the 7, there will be a Slido poll, so be ready for that. This man was of normal mental status, as you can see at the end, but something happened to him. And this is your chance now to answer the Slido poll. He's not jaundiced, so the flapping we saw is not asterixis, or alternately, it could be from kidney failure or severe COPD, or many prescription drugs can cause this, or 2 and 3 above. Give your best answer, please.
Okay, Tom, I'll be reading the poll results to you. So far, number 2 and number 3 above is the most chosen answer, followed by a third of people saying many prescription drugs can cause asterixis.
Good.
So
okay.
70% saying 2 and 3.
Well, that maybe the question was too leading, because it astonishes me that so many people, and it pleases me that so many people would be aware that asterixis is a final common pathway sign, in effect, of multiple problems affecting the brain. I tend to think of it, you can use a Greek word, encephalopathy, or you can use an English word, the brain is sick, or a sick brain. And I think the best answer there is 2 and 3 above, that more prescription drugs than we realize can cause this. In this case, it was gabapentin at a relatively standard dose that a superb nephrologist had ordered, forgetting perhaps that the patient had impaired kidney function and impaired ability to excrete it. But it's an example meant to provoke you. Now, this is a longer video, and I ask you to think, how did what happened to these people occur? And we may come back to that in the question period. I'm just going to pause it there for a second. It turns out there's a happy coincidence that later today we're going to hear about bupropion, tramadol, and perhaps nortriptyline and venlafaxine. I think the only one of the 5 drugs that she was taking that we won't cover today unless people ask is topiramate. I'll just stop it to let you absorb that for a minute. These are very high doses of multiple drugs. And for those of you who haven't seen this, ketamine has begun to make its way into the pain world. I would say this is a relatively extreme combination of drugs. You will say that's an extreme case, I think, and both of them are extreme cases, but perhaps in the question period, if we have time, some of the audience can tell us whether this is as extreme as it looks. And I think the natural reaction of most of us who are prescribers would be, well, I don't have anyone like that. Of course not. But does it remind you of anyone else's practice or any patients you've seen? And would you trust yourself to pick up on the impairments? I think, again, it might be interesting to have some comments from the audience, even by way of questions, that it should be obvious that both the first woman and the second man were substantial. Well, you didn't get to see the first woman when she was better, but both of them, in fact, improved dramatically once drugs were stopped. But was it immediately obvious what was wrong with them? That's a question. And I think one point I'm trying to make with this video is that we should be observing people carefully while we talk to them. Look for myoclonic jerks, for example, which are little twitching movements, and always test for asterixis if you think somebody might be impaired and is taking drugs affecting the brain. And that includes potentially anything affecting the brain. So here's another one. There's no slow to pull on the last one, but this one there will be to follow. And you may now answer the questions. Which do you think is the best answer?
Okay, Tom, again, I'll be reading out the poll results, and 75% so far, all of the above. Many of our drugs could be the culprits. 93%, all of the above. So it looks like almost everyone is saying option number 5.
Well, we've got a very sophisticated audience, or I failed entirely to pose genuine questions. They seem too rhetorical maybe to people, but I'm pleased by that. Maybe and some of you in the audience would volunteer to be my doctor when I need one. I'm going to try to bring out some of this. If you think about what you saw.
Tom, may I interrupt for just 1 second? Just to give you a sense of time, it's 15 minutes to the originally scheduled break, or shorter, if we want to break earlier than 10:15.
Okay.
Just to give you a sense of where we're at. Thanks.
So what did you think about her face? And would you describe her as having a blunted affect? For example, when asked, do you have schizophrenia? She says, I don't think so, maybe I do. Is that a wry sense of humor, or does she have much expression, et cetera? And if you were concerned that she's Parkinsonized, would you stop or reduce any of these drugs? I think hopefully the obvious answer to that is quetiapine, but if you try a Google search of pregabalin, zopiclone, and mirtazapine and Parkinsonism, and drug-induced Parkinsonism, you may be interested to know that you'll find reports of drug-induced Parkinsonism with pregabalin and mirtazapine. I suspected it for mirtazapine. I didn't know that about pregabalin until I tried it myself a couple of days ago. So I want you to look now at difference 10 days later. It used to be relatively acceptable for a doctor to say something like that, but there's a lesson, whether you like what I said here at the end or not, there's a lesson which is that if you're wondering if someone is Parkinsonized or not, try provoking them by something that's not frankly offensive, and see whether you can get a smile out of them. And if you notice her face dimpled and wrinkled a little bit around her mouth, and she is clearly very different from she was before. So I think there are a lot of different ways to analyze the difference. Every time I look at this, I notice something different. And the pearl is really, if you recognize what drugs are potential obvious or potential dopamine antagonists, which can include drugs for serious nausea like metoclopramide and prochlorperazine, but also SSRI, antidepressants, probably venlafaxine, et cetera, maybe duloxetine. If you're at all suspicious about it, challenge yourself and then challenge later. And anyone could do that, including not only doctors and nurse practitioners as prescribers, but also dispensing pharmacists, hospital pharmacists, nurses. And I think this is a strong opinion from me, but root out the expression flat affect. Most people in my teaching experience would have described her as having had a flat affect rather than saying that she's Parkinsonized. So unless you're absolutely certain that there's no dopamine antagonist at play, don't even use that term. I'm not sure if there's any utility to it myself, as opposed to using English that the person has limited facial expression.
Okay, Tom. 100% of answers for all of the above.
Darn, I made these way too easy, didn't I? Okay, so everyone will then, in our audience, is aware that tricyclics tend to block alpha receptors and cause postural hypotension. So that's good. That's going to make my life easier in another moment or two. But some of the things it's taken me, essentially my career, to really begin to understand is one should actually listen for dry mouth. If the person sounds a bit like the woman who was wearing orange in the second video, this may be dry mouth. Look for a water bottle. In younger people, it's part of the culture. In maybe fading because of plastic, but in older people, it was never part of the culture to carry a water bottle around. And look at the health of the teeth and gums because of suppression of saliva. And ask not just about, is it hard to pee, but what about emptying the bladder? And the visual focus issue is not simply, do you have blurry vision, but do you have difficulty adjusting your vision if you look from near to far or vice versa? And we'll come to the last one momentarily. So here's something rather different to think about. What is this woman actually telling us?
Okay, Tom, so 71% of the participants say she thinks she shouldn't have taken it all. It blunted her good emotions. And about 10% saying venlafaxine acted as a tranquilizer. Sorry, 90%, option 4.
Yeah.
About 10% option 3.
I put this in really to provoke thought because people like to use the expression mood stabilizer, which I think is probably a marketing term. It doesn't, I'm not sure if it really has a scientific meaning, or even antidepressant. Or tranquilizer was a bad old word from the 1950s and 60s, which maybe actually was describing better. So I'm going to show you one last video for those of you who know all about alpha blockade, to challenge you. Are you doing this? So this is what happened to him. I've highlighted in yellow or orange the standing pressure score. I repeated it. And then once the dizipramine was stopped, it was much closer to normal, or potentially normal, from 132 systolic supine to 114 or even 108 standing, but his heart rate does not increase so much. So he was on a lot of other drugs, that man, but the summary is that the standing blood pressure drops a lot, the standing heart rate rises a lot. If you count for 10 or 15 seconds and you're used to counting heart rate, you don't need much longer than that. And we need the heart rate because it confirms that the heart is attempting to compensate for inadequate preload, just like hemorrhage, volume depletion, or pulmonary embolism, or even cardiomyopathy, perhaps. But the pearl is, when a patient complains of dizziness, check for drugs that lower the standing blood pressure, and then measure it in this way. And we were all taught that, I hope, but wouldn't hurt some of us to practice it more often. So now's your chance to answer the last question, whether you actually do this, or if you're a pharmacist, do you instruct anyone to do this?
Okay, Tom, so right now we have the votes are fluctuating. Half about once every few years when patient complains of dizziness. 23% as a pharmacist, I don't check, but I tell patients to check themselves using a home monitor. About 20% at least once after a patient starts a relevant drug.
Well, you believe it, Alan? Aaron, I guess we'll throw that to the audience. Do we believe the answers or not? I hope so. I learned something from COVID. I learned a lot of things, I guess, but one innovation is that while doing a Zoom interview with a patient, he mentioned at the end that he had methyltrimeprazine, which I hadn't been aware of, and also had told me he's dizzy. So I said, I don't think that's such a good idea. Why don't you look it up on Wikipedia, and I think you'll be convinced you should stop it. And later the same day, he emailed me to say he read Wikipedia, he got hold of a blood pressure monitor, and he performed that measurement. So I followed up with him. On the left as well, he was taking methyltrimeprazine. On the right is once he had stopped it, and he proved to me that patients can do this themselves just fine, but it took a little bit of instruction. The first time he didn't record the heart rate, so I don't have it. The second time he did. So I think anybody could teach patients to do this if they have a blood pressure machine or the capacity to do it themselves. And one last lesson, another pearl, that the pharmacist helped me to close the loop by sending me an annoying fax asking, did you mean to stop methyltrimeprazine? And I thought about it for a minute and they answered promptly, yes, I did. Perhaps I should have added a thank you on there, but an example of how a deprescribing prescription is actually very important when we stop things. I'm going to finish there, Aaron.
Great, Tom. I'm sure everyone would agree with me. Thank you for a wonderful presentation. I've seen some of those videos before and they still induce so much emotion, and they're a fantastic way to teach. So thank you very much. We have just a few minutes for questions. So the first one, can you comment on people that are reluctant to come off medications? How do you engage them?
Well, I usually start by asking them how much they know about the drug, and then I really try to pin them down on whether they're sure it has benefited them. And in situations of polypharmacy, the most common answer after, oh yes, definitely, is, well, if I ask, how do you know, given there are multiple drugs, the most common answer is, gee, you know, I never really thought about that before. Now that you mention it, I'm not sure because they were started at the same time. And that's the opening. I think rapport, as in anything else in healthcare, is always critical.
Okay, thank you. And I think I'll get to two more questions. The next one is, these cocktails of pain meds, opioids, antiepileptics, psychotropics are common in patients with substance abuse disorder and situations of poverty. What would you do if one of these patients in your videos was homeless or living in a short-term shelter? Does your approach change?
Do you mind reading that one again? I got distracted by something in chat.
Okay, so what they're saying is many of these types of patients with this cocktail of opioids, antiepileptics, antipsychotics are quite common in patients with substance abuse disorder living in poverty. What would you do if one of the patients in your video was homeless or living in a short-term shelter?
Well, that's much more challenging, obviously. I think probably one would start in the same way with the question about what are their hopes and what are they trying to achieve. And if the person says, well, my life is terrible, I want to be out of it, I don't want to feel what I'm feeling, then probably it's hopeless until they're housed. And even then it will be very difficult. I admire those people who are working in that field and trying to deal with that.
Okay, thank you, Tom. And then the final question, could you comment on your approach to deprescribing sleeping medications, particularly when you're concerned regarding side effects while the patient is resistant to stopping?
Well, I've taken always a much more radical approach, and it partly reflects my hospital background. Most of my career was in hospital medicine, where I had power and control to prevent people from taking things. But I also had the responsibility of being on call. Anytime I've done something radical, such as the woman who was so Parkinsonized, I've made clear in the chart and to nurses, you may call me 24 hours a day if there's a problem. So I think it goes, if one is going to be more radical, one has the responsibility to be available and take responsibility. But I advocate that approach because it's so much clearer. Others would advocate do one thing at a time and go slowly because you may induce withdrawal. Interestingly, I induced a very unpleasant withdrawal in the woman in the second video who was wearing an orange dress, but she forgave me for it because she was so much better. If I could do that again, I would have been a little bit more gentle about it.
Okay. Well, thank you for answering the questions, Tom, and for a wonderful presentation.